Hello and welcome back to the Rheummates podcast, part of the rheumatology.physio podcasts with me, Jack March, and this month I am joined by Mike Dare, which is always a treat. And this month we've done an interview, which we try to do every now and then, and it's absolutely brilliant, so we'll get on to that in a minute. We've got a new At a Glance guide out next week, all on about the hip, written by Rob Tyre. It's absolutely brilliant and in the same vein as all the other At a Glance books, so one to absolutely add to your collection. It's really good. They are going to be available next week on pre-order to just a few select people. So if you want to be on that select list, then you can find me on social media. Just type rheumatology.physio into Twitter, Instagram, LinkedIn, Facebook, and I'll come up, and then just DM me your email address and let me know that you want to be on that pre-order mailing list. It's going to be a bit of a discount on that for the pre-orders, and those will be available as hard copies to anybody in the UK and Europe, but they'll also be available as ebooks if you don't want a hard copy or if you live outside of Europe. Unfortunately, had to turn off international shipping outside of Europe because we were losing so many orders. It was costing me a fortune. So unfortunately for those of you outside of Europe, you'll need to get an ebook, and then you feel free, of course, to print that. Don't forget, we've got Therapy Live coming out as this podcast comes out. That'll be in just 9 days, and if you haven't got a ticket yet, then why on earth not? But I'll be speaking there on axial spondyloarthritis in women, so that should be great. Tickets are free. Just head to therapylive.co.uk, therapy-live.co.uk, I apologise, and you'll find the tickets there for free. Finally, on to this podcast. So we were very lucky to speak to Dr. Ai Lyn Tan, who Mike and I follow around on Twitter like little ducklings, and every time she tweets out some research that she's been involved in, then inevitably it's absolutely brilliant. So we threw out the idea of her coming onto the podcast to talk to us, and she fortunately said yes. So here we are. We recorded with her. The only big downside to this recording is that unfortunately we couldn't get Dr. Tan's time for approximately 45 hours. You'll notice as we go through that we really wanted to pick her brains on a lot of different things. So Dr. Tan is a consultant rheumatologist in Leeds. She's an associate professor. She researches arthritis, muscles, exercise, MRIs, ultrasound, and as you'll hear in this interview, is somewhat of a genius and all-around lovely person. So do follow her on Twitter. She's Dr. Ai Lyn Tan, and certainly learn from her an absolute ton. In this, we particularly talk about the effect of exercise on inflammation, why, when, and how we should use this to help our patients. So on with the interview. Okay, brilliant. So we are back for another rheumatology podcast. I am joined by Mike, as usual. And today we've got a very special guest. It's our second guest on the podcast. We've got Ai Lyn Tan, which is, we're really excited about this. I know Mike and I have been sort of trying to decide who we wanted to get on to talk about various things in rheumatology, and Dr. Tan was sort of way up on our list because we've interacted a few times on Twitter between the three of us, haven't we, with regards to different research things. So really happy to talk about this, and we're going to talk about exercise and inflammation and its various causes and guises, and what really happens when you exercise and what happens to your inflammatory system and inflammatory arthritis. So the first thing I'm going to get us to do is, would you mind introducing yourself to our listeners, Ai Lyn, and then we can crack on from there.
Yeah, sure. Thanks for inviting me to this episode of your podcast. Really looking forward to the next maybe half an hour of interesting chats. So I'm a consultant rheumatologist in Leeds. I'm an academic rheumatologist, so that means that half the time I work in the NHS as a doctor, and then the other half the time I am involved in research in rheumatology. So my main research interest is using imaging to understand the pathogenesis of rheumatological conditions, so arthritis, that includes rheumatoid arthritis, spondyloarthritis, psoriatic arthritis, osteoarthritis. And latterly, I've been using MRI alongside very clever colleagues in medical physics and radiology, and trying to understand what goes on in the muscle of rheumatic diseases. So I've looked at rheumatoid arthritis and also aging, particularly with sarcopenia, aging muscles. And hopefully going to understand a bit about muscles involvement in COVID as well. Very, very timely to understand what goes on. And I guess that's kind of related to the topic we're talking about in terms of exercise.
Yeah, perfect. Mike and I on a previous one of our podcasts talked about your paper you did where you were measuring muscle volume in rheumatoid arthritis patients. That was absolutely fascinating. I now feel like I regret not booking you for about a 45-hour podcast where we could ask you about all of your research projects that you've got going on, because I can see Mike nodding away going he wants to ask you loads of questions on those, but we'll try and narrow it down a little bit. So the first question I want us to get into really is there a significant difference for the inflammatory arthritis cohorts if in sort of inactive versus active patients? I think that's something we need to understand first. What's the big problem with people with inflammatory arthritis if they're inactive?
So I guess there is also a differentiation in the group of people with inflammatory arthritis as to whether they are having an active inflammatory episode or active disease, or if they are in remission or well controlled on therapy. So there's a distinction between those two groups as well as being active or inactive. On the whole, the benefits of being active, actually rephrase that because you're asking about if they're inactive. So the downside of being inactive in people with inflammatory conditions, or in fact any of us, anyone, is that obviously we are not getting the benefit of being active. But particularly in people with inflammatory arthritis, being active means that they are moving more, and movement is always good to keep the joints healthy. To describe very briefly the benefits. So when we move our joints, we keep it in working order. We stop it from sort of stiffening up, and this is so significant in people with arthritis. And movement promotes health in the muscles that are very important to control joint stability and joint health. So I think there's a lot of advantage in movement for everyone, but even more so in people with inflammatory arthritis.
Yeah, perfect. And what about with regards to things like other factors as well? So you mentioned about sort of joint health specifically. What about wider health? I know Mike and I again have discussed previously about sort of abdominal fat being an issue. So how about things like using it as a way of getting out calories, that kind of thing? Is there on those sort of wider health aspects, how's that for inflammatory arthritis as well?
Yeah, so the additional benefits of being active and exercise for people with inflammatory conditions, inflammatory arthritis, is that in addition to the joint health and the muscle health that are obviously related to arthritis, the effect of exercise, there is evidence that it reduces inflammation, and this is not inflammation specific to joints. So as you know, inflammatory conditions like arthritis, the inflammatory response don't often just focus on the joints. It can be a systemic effect, and being a systemic effect, it has consequences on other parts of the body, including the cardiovascular system. You mentioned the fat, sarcopenia being related as well. So, and also additional to the anatomical benefits of exercise is the mental health benefits as well, even very significantly, and that's got a snowball effect on the rest of the body. So, you exercise, improve your mental health, you feel better, you want to do more exercise, you're more motivated, you get the health benefits, the structural benefits as a result. So it just goes on and on and on. This is when we need a 45-hour podcast to talk about all the benefits of exercise.
No, for sure, exactly. Mike, I wonder if you comment on the majority of the people that you see in clinic, because you see a lot more clinical patients than I do. Do you think that the people coming in to see you are already understanding that they need to move more, and as a result just need some help as to how that best occurs? Or do you see a lot of people who they feel like they want to remain more sedentary because it's immediately more comfortable? Do you think, is there people seeing on one side versus the other, do you think?
I think it's multifactorial. I think it's kind of nice if you get a new rheumatoid or a PSA patient who's running marathons or those kind of things, because you automatically know the prognosis for that patient's going to be pretty good, because they're active, they're generally not smokers, and they just do better. And I'm sure Dr. Tan will agree, they just do better on their disease-modifying medications. I just think there's this societal misconception, really, that if you have arthritis, in inverted commas, irrespective of what your diagnosis is that if you put stress on your muscles and joints, it's going to speed up the process or worsen the disability long-term associated with that. And, as Dr. Tan said, I think we've got good evidence now that, in fact, the opposite is true, is that your cartilage, your articular cartilage health and your kind of arthrogenic inflammation and systemic inflammation is just much better if you're physically active. So I think it is more of a mentality thing. And it's just about challenging, I guess, those internal beliefs from patients more than anything. And it is a challenge to kind of change that mentality and get patients more active. But again, as Dr. Tan said, I think if someone is having low disease activity or in remission, it's a lot easier to get them active than, if they're really sitting on the higher disease activity realm, really.
I totally get what Mike is saying. It's very, very familiar and interesting. But I think for me and Mike, that's really what we see. And I think there's two sides to this, because there's the obviously the benefit for the patients, but also the healthcare professionals who are educated to sort of share the knowledge to patients is very important. And there are studies looking at the knowledge of healthcare professionals in terms of the benefit of exercise for these patients. And it's fascinating to see from this study that even healthcare professionals, not all healthcare professionals, recognize the full benefit of exercise in people with arthritis. In that some still believe that, for example, exercise is bad for the knee joints, and this is from healthcare professionals. And if I think healthcare professionals don't get it consistent, then it's difficult for patients to believe and trust what is the right thing to do. And as a result, this is going to have a major impact on motivation that Mike was referring to. How will patients be motivated to do the right thing and know what is right for them? And studies have also shown that patients sometimes you don't know what you don't know. So we need to have that knowledge to impart to patients and share with them that actually it is okay to exercise even though you've got arthritis. And if anything, it is good to exercise, and that they need that permission to exercise to help with their motivation.
Yeah, for sure. And that certainly echoes what I see from my role, where I'm more of an educator of therapists, that I do see people, they do go very softly with these patients. And there is, every single course that I run, I can guarantee someone will ask me about, well, what happens if you do exercise with, let's say, a rheumatoid patient and they get symptoms afterwards? What symptoms should they accept as a result of their exercise? And I basically say, and I want your comment on this, Ai Lyn, whether I'm correct here. I basically say, well, if the patient can tolerate the symptoms that they're receiving in the short term. So I usually go 6 to 24 hours. I don't want it extending past that because that's just not very nice. As long as the symptoms that they get are tolerable, then that's absolutely fine to be exercising through that. If they can't tolerate it, bring tears to their eyes, or that's stopping them from doing other things, then that's too much. Is that a fair line in the sand to draw, or should we have more specific markers, like if their knee gets very, very red, for example? Are there anything like that I should be teaching people?
I think I would entirely agree with your approach towards guiding patients, absolutely, because I really believe in sort of almost tailor-made your instructions to the specific patients, because you're going to know the patient best as a therapist. And it's all to do with reassuring patients and helping encourage them to motivate them and to say it's actually okay. So for example, as you said, patients need to be reassured that when you start doing a new form of movement or exercise, you anticipate some form of discomfort, and that's okay. And the muscles do feel a bit stiffer for the next few days, and that's okay, natural process of a new exercise. But anything more, for example, as you said about wincing or crying, that's a warning sign. Just the same for any of us. If we do something and we say, ouch, that's terrible, we know it's our body's warning system to tell us that's not the right thing to do. But if it's a bit of an aching or a toothache kind of soreness, that's okay. That's just muscle working hard. It's working on the muscles. And what I also tell patients is that they need to do it regularly, but maybe cut it down to the intensity and duration that they can manage as you described, but keep doing it. Maybe rest for a day or two if they feel it's too intense, but pick it up again and keep doing it for about 2 months before they see any benefit. And this is like managing expectations as well, because there are studies that have shown that the pain level do improve, but it takes up to 8 weeks to show that. And so patients need to be informed and say, it's okay, you might not feel any benefit. If anything, you could feel worse, and that's fine. And if you persist with it for a couple of months, you will eventually feel the benefit. And it's just, again, telling them our experience, the evidence, and give them permission to feel that it's okay, but to watch out for warning signs like, out of character pain, for example.
Yeah, for sure. Mike, I just wondered if you comment, because I think one of the things that physios are guilty of is, and it'd be interesting to hear if Ai Lyn thinks this as well, is that physios often think that exercise is a bit of a magic bullet and it is really good for everything, whereas actually in reality, when we look at the research, exercise is one component, and mental health is another component, especially in rheumatology. Disease modifying medication is a big component, diet is a component, not smoking is a component. When you see patients that have seen physiotherapists, osteopaths, etc., do you feel like those other components are being addressed, or do you think they're just concentrating on exercise?
It's a good question, and I actually listened to a podcast from the ME physio group a couple of evenings ago about this, which was really fascinating, and I recommend it if anyone listening to this podcast hasn't listened to it. And I think it's exactly that, is so many physios try and sell exercise as a magic bullet. And I think it really depends on which condition we're referring to, and the many comorbidities and multifactorial kind of contributions to a patient that's sitting in front of you. And I think it's about having open and honest discussions with patients about their condition. So, for example, if a patient does have rheumatoid or axial spondyloarthritis, exercise is not going to be a magic bullet that's going to make them brand new again. And as Dr. Tan said, it takes dedication over many months to see the benefits of this. And I always find it fascinating how a patient would be really happy to take methotrexate, for example, for 10 weeks to start seeing their disease activity come down. But after a week or two of going for walks or cycling, they just say it's not working, kind of thing. So that always interests me. But I think it's about having open and honest discussions with patients. and not really selling exercise as this magic medicine that's going to take away your osteoarthritis, or cure your axial spondyloarthritis or your chronic fatigue syndrome. But it can have benefits in certain areas, and it may flare up other areas. So it's just about, as Dr. Tan said, setting those expectations for patients and being completely transparent with it. And also, I guess, adjusting your advice and your program and your recommendations to the patient according to their condition, the activity or disease activity that they have, and other comorbidities.
Yeah, you've led me lovely into my next question, which to Ai Lyn was about, you mentioned right at the beginning about when people have more active disease versus less active disease, and whether you call that a flare up or whatever we describe it as. Do you feel like, again, I use the same sort of pattern that I would, where I say, look, if your symptoms are worse, just still use the same tolerance level marker. So you'll tolerate less, but that's fine because you're feeling worse. Do you feel like, is that still appropriate in that situation, or do we need to tail back more if they're having a, inverted commas, flare up?
I think initially it's appropriate just to test how they can tolerate. So I guess you're talking maybe using percentage rather than say do that 10 times. Kind of thing, because it's then individualized. And I think it's entirely appropriate to suggest that initially. And I think, again, patients will know when that's not right. I think, again, listen to the body's warning sign, the difference between an ache and a sharp pain or a really uncomfortable pain. And I think during a flare-up, if the joint is really big and swollen and particularly red, I would probably just hold back significantly. They might want to do a bit of stretching if they want to, just to keep it mobile, but maybe just rest and get the active joint treated and then resume exercise as soon as possibly can. So again, very individualized, but and I guess the danger here is when patients think, oh, actually my joints are so severe, I need to exercise more to get it down. And actually what I tend to tell patients is actually the need to exercise regularly is, and the best time to do it is when your joints are really well controlled, because you've got no pain, you've got no stiffness, you're able to do the exercises more effectively and gain maximum benefit. However, when you're in pain and you're having a flare up, the exercise isn't going to contribute any benefit because you're unable to do it properly, and yeah, hold back as needs be, depending on the level of inflammation.
And if you've got a relatively localized flare up, so let's say it makes it easy if you just say the knee is really flared up, it's really red, really hot, really angry. Would you still tail back all the exercises, or could you adapt them so you were doing just upper limb exercises, for example? Like, I know that we're obviously talking about in systemic inflammation, so I'm just wondering about whether actually doing upper limb exercises, getting everything flowing around, whether that's going to be problematic, or whether you could still carry on with that as long as that was tolerable.
I would personally say carry on with the other exercises in the other parts of the body that isn't inflamed, and the person is able to carry on with them relatively comfortably and rest the affected joints. So obviously it's different if somebody's got a flare up where many joints are affected, then yeah, it's different. But if it's only one joint that's affected, for example the knee joint, then if the person's comfortable doing upper limb exercises, upper body exercises, absolutely, or exercises for the other leg, by all means, there's no reason why they can't do that.
I'm really enjoying how much you're agreeing with me. It makes me feel really good. I wanted to ask about, I had a question the other day on one of my courses, and I genuinely didn't know the answer. And Mike, I'd be interested in your comments here as well. In that, what the physio had a patient come into them, and they wanted to investigate them for a possible rheumatology disorder, but the patient was very, very active. They ran every day, and the physio asked me whether they should ask the patient to stop exercising for a few days before the blood tests, in order to get an accurate marker of the inflammation, almost as if like you would potentially maybe say stop anti-inflammatories or something. Does exercise have a significant alteration either up or down of those inflammatory markers to make it worth them stopping for a few days, or is that just sort of pointless?
Who's going first?
Well, I can't give you any research to back up that question or my response to that. I think Dr. Tan will probably have done all the research to back up her points on that. But personally, in clinic and with the consultants that I work with, we've never really advised people to stop exercising in anticipation for a blood test or any imaging for that matter. So I personally have never come across any concrete evidence that there'd be a massive reduction in CRP because of exercise. But I mean, Dr. Tan may prove me wrong, but that's just a Mike et al. Clinical opinion. So
I think there is a short answer and a long answer to that question. The short answer is that, yeah, I don't think there's enough evidence to recommend stopping exercise for somebody who does it every day in order to have an accurate measurement of the inflammatory markers. The reason for that, I'm personally not aware of specific studies into that. So it'll be interesting to hear from any of the podcast listeners if they have evidence to respond. And I think this may be because so the long answer is that there's probably a slight, maybe insignificant change to the inflammatory markers related to exercise, not enough to say stop the exercise so that we can have an accurate look at the inflammatory response. And also, it depends on whether the exercise is an acute phenomenon or an ongoing. As you said, this person runs every day, so it's a normal activity for this particular person, which may be different to somebody else who doesn't do any running and suddenly go and run even a mile. That's completely different because so there is the short-term effect of acute bout of exercise on the inflammatory response, which it can increase a transient short-term inflammatory response, as opposed to somebody who does regular exercise, whereby actually on long run they have reduced inflammation in their body as a result of the continuous regular exercise.
Yeah, no, great. I didn't think there was. It's just one of those things I thought, I don't know. The other thing that crosses my mind there is, you know, you said it would be a small change. I mean, I struggle to think of clinical scenarios where, you know, if your CRP went down by 5 or up by 5, whether that would really change your clinical reasoning process. So it'd have to be a huge change, wouldn't it, I think, to really change your clinical decision making there. I wondered if you would comment, Ai Lyn, on, we talked briefly just a minute ago about the study you guys did about the muscle volume between newly diagnosed, it was new onset symptoms, wasn't it? New active disease and managed disease, if I remember it correctly. Would you comment on, let's say that Mike's got a new patient in his clinic and he thinks they might have rheumatoid arthritis. How much emphasis would you say at that point should we be putting on patients being active or even increasing their activity levels to try and reduce that drop off of that muscle volume loss that you showed?
So yeah, so the study you're referring to, which is published in Rheumatology, is using MRI or quantitative MRI specifically to look at the thigh muscles of rheumatoid patients, and we looked at 3 groups. So we looked at new rheumatoid arthritis patients just diagnosed, not had any steroids or not had any DMAT therapy, so completely naive to treatment, compared to patients who are obviously on therapy and in clinical remission or sustained clinical remission based on DAS activity, and also a group of rheumatoid patients who are deemed active disease, again based on disease activity score. And what's fascinating, and the caveat is that this is a cross-sectional study, so it's not longitudinal. What we saw was that across all these 3 groups of people, their muscles are not as healthy or as normal as a control group. So we also have a healthy control group who have no arthritis and matched to gender and age. And even in the patients in clinical remission, their muscles are still different compared to the healthy people. Particularly, we measure muscle volume as well as a measure called T2, which is a quantitative MR measure. And so I think based on this, this is a small study, it's cross-sectional, it suggests that potentially there's a signal that suggests that exercise, as we know, can maintain muscle bulk and muscle strength, may be very important in patients with rheumatoid arthritis. It would be fascinating to see if, particularly in the group who are in remission, what their VAS scores are like, what their other systemic features, the fatigue levels, the energy levels, their quality of life is, despite the fact that they have zero tenders, zero swollen, CRP, ES are all normal, all markers of arthritis are normal. However, are they actually truly well? And if they're not, is it to do with the muscles? Could the muscles explain it? In comparison to maybe somebody who's very active with rheumatoid, whose muscles are maybe different to somebody who's inactive in remission. So these are interesting questions that we still don't really fully know.
Perfect. Yeah. And Mike, what do you do when you've got someone you suspect of having that rheumatoid arthritic pattern with regards to getting them start being active or increasing their activity? How do you go about that?
Well, I think when I started working in rheumatology, predominantly about 5 years ago, I was quite cautious with patients with inflammatory arthritis. So, with rheumatoid patients, we'd look at splinting and gentle, hand stretches and so forth. And your axbar patients, getting them to do gentle spinal range of motion and hip abduction stuff. And now I tend to treat inflammatory arthritis patients just like the average Joe, as long as their disease activity is let's say low disease activity or even slightly on the moderate level on the disease activity scores. I just push them to be active. So I discuss with them what their hobbies are and what they enjoy, and most of them would enjoy maybe swimming or walking or running or some weightlifting or whatever it is, and I just get them doing that and get them kind of sticking to a schedule of being active 2 or 3 times a week, doing what they enjoy, getting their heart rate up and just being active. And I think there's a lot of research that shows, particularly in axbar patients, is good cardiovascular high intensity exercise or weight training exercise is just as good as spinal range of motion exercise in kind of maintaining fitness, really. So I think my mentality's definitely changed when it comes to managing these patients, and hopefully the whole physio realm will move to a more get patients active mentality, as opposed to pittering on about looking at certain areas of the body in compartments. Really, I think it's just about getting your patient active, getting that 3 or 4 hours of good exercise in a week, and basically helping them enjoy their lives. That's the important thing, I think.
Yeah, perfect. We've just got the last couple of minutes, really, but I was just going to ask you, Ai Lyn, about whether there's anything that these patients shouldn't do. I've had a number of clinical queries in relatively recent history about younger patients, sort of sub 25, whether they should be avoiding contact sports, those kind of things. They're controlled on their drugs. It's not, I've no concerns there, but should they be avoiding contact sports at a young age or anything like that?
Short answer is no.
Excellent.
Well, I mean, even in people older than what you just said, 30s, 40s, 50s, whatever age, basically, age is not the matter here. And I think I have patients as well coming to say, I do a lot of this or that sport, which is very vigorous sports, and is it okay to continue to doing that now that I've got arthritis? Absolutely, no reason to stop at all. If anything, yes, do carry on, particularly if they've been doing that since whenever. So it's something that they've enjoyed clearly, and definitely encourage them to carry on.
Brilliant. Perfect. I'm definitely going to get you to come back, Dr. Tan, if you keep agreeing with me this much. It's really nice. So I want to thank both of you for spending half an hour with me this evening and chatting over these topics. It was a really useful conversation to have. And I hope that physios and all the other therapists and anybody else that listens to this is reassured and be a bit more confident with pushing these patients a little bit harder with regards to exercise and getting them more active. Where can we find more out about you, Ai Lyn? Obviously, you're working out of Leeds with your sort of all-star consultant group there. It's like the who's who of works in rheumatology. I was wondering whether this is a ridiculous question, but I was wondering whether there's like a competition between Leeds and Bath in any way, because they sort of seem to be the two sort of competing they don't compete, do you, but two sort of very high profile rheumatology departments.
We're all one big happy family of rheumatologists wherever we are in the world.
Brilliant. Where can we find you on social media and that kind of thing?
Yeah, so you can follow me on Twitter, and it's very simple. It's at Dr Ai Lyn Tan. So that's DrAiLynTan, all one word. I've got another Twitter account that talks about running mainly, if you want to follow me there as well, which is at Ai_Lyn_runner. And I'm on Instagram, but again, only pictures of me running every day. I am almost running every day for almost a year now. So with the same handle at Ai_Lyn_runner as well. So yeah, I'm on those sites.
Brilliant, excellent. And certainly Mike and I, whenever you tweet a paper, we're both always straight on it, thinking what's come out that's interesting now. So yeah, we're fascinating what research you guys come out with in the near future as well. So thank you very much for spending your time with us, and hopefully we'll get you back again soon, and we'll talk about. Yeah, Mike's desperate to talk about imaging. I can see it behind his eyes.
Thank you for inviting me. Thank you.